Quinto año.
Quinto año. El joven Enrique se encuentra ahí. No lo veo, Enrique. Enrique Victoria. ¿Qué tal?
Alert
¿Qué tal,
from
Enrique?
updates
¿Cómo
not
estás?
installed.
Ok. Bueno, voy a
Alert from updates
empezar
not installed.
Espérame un segundo. No sé por qué no me...
Alert from updates not installed.
Ok, aquí vamos. Right. Okay, les voy a poner una presentación. Vamos a hablar sobre el diagnóstico y el manejo de enfermedad periférica arterial. Y les voy a dar esto en inglés. ¿Está bien? No les estoy escuchando. Espérenme un segundo. Ok, voy a poner screen sharing. Ustedes pueden ver mi pantalla, ¿no? ¿Ahí?
Aún no.
Todavía no, doctor.
Ok. ¿Ahora?
No.
A ver, vamos a ver cómo hago el screen sharing acá. Stop sharing. Share screen. Stop. Voy a poder hacer sharing. Ok, ahora ven, ¿no? ¿Sí?
No.
¿Nada?
Aún no.
Ok. Vamos a ver qué es lo que estoy haciendo. Ya, ahora sí. Ok, ¿ahora ven?
Sí.
Ok, entonces vamos a hablar, les voy a hablar en inglés para que practiquen un poco el inglés y si tienen alguna pregunta me hacen pausar y les puedo hacer la traducción. So what we're going to do is we're going to talk about the diagnosis and management of peripheral arterial occlusive disease. Okay, so that's me, James Antezana. I'm the Chief Division Vascular Surgery and Director of the Cath Lab at the Antezana Institute of Vascular Health and Wellness, as well as SCGVS. And I'm going to talk about the epidemiology of PAD.
Excuse me, male needs your attention.
And if I can shut this thing up, that would be awesome. Hang on one second here. All right, quit. I don't want to listen to that. All right, and let's continue our slideshow. So it's very important to understand that PAD, or peripheral arterial occlusive disease, affects 8 to 12 million Americans. And I'm sure that the incidence of this in Panama is also elevated because you guys are part of that circle of a developed nation. People that smoke, diabetics, hypertensives, hyperlipidemia, all those individuals will have the predisposition of developing atherosclerosis in the periphery. But it's interesting to mention that along with all these comorbidities, you've got patients who are smokers that have the highest prevalence because they can accelerate the process of atherosclerosis. Okay? Patients with PAD are also known to have coronary artery disease. About 30% of these patients with PAD will have coronary artery disease. They'll also have a risk for myocardial infarction, stroke, and vascular death over 5 years. So this is a very grave situation, right? So many times these patients will run around and walk and they're completely asymptomatic. So it's very important to identify the situation to save these people's legs and their lives. And the way we do it is with a good clinical examination. So unfortunately, the specialists have been poorly taught to do complete clinical examinations. They neglect to examine the feet, the upper extremities, feel pulses, etc. So it doesn't only pertain to internal medicine clinicians, but it also pertains to clinicians of different specialties. Obviously, vascular surgeons were very, tactile, and we'd like to make sure that we examine all the vascular beds to ascertain that there is no issues. Primarily primary care, internal medicine, those are the specialists that, when they're doing their clinical examination, they sometimes tend to bypass that peripheral vascular exam. So who is affected by this? The elderly, patients with coronary artery disease. As we mentioned, 30% of people with PAD will have coronary artery disease. Smokers, diabetics, patients with end-stage renal disease, patients with hypercholesterolemia, family history of hypercholesterolemia, CAD, PAD, hypertension, and the male gender. It affects males more than it does females. What do you guys think so far? ¿Qué piensan? You guys are catching up with everything that I'm saying? Yanni? ¿Alguna pregunta? ¿Están entendiendo todo?
Sí, doctor.
Okay, great. Excellent. So that's the who. And this is the anatomy at, from a zoom out perspective. So, you guys are all familiar with the anatomy, so I don't have to go through all of this, correct? Okay. All right. So when we talk about PAD, we primarily talk about the vessels that affect the distal aorta in this section. Can you guys see my pointer moving around the aorta? Okay, so it all starts obviously up here in the aortic arch. You've got the vessels that go from off the aortic arch, the innominate artery, you've got the common carotid on the left side, and you have the subclavian artery on the left side. So you've got 3 branches that usually come off of a pretty typical normal aorta. Now there's very different types of arches, including a bovine arch, which has a different anatomic configuration. But the normal arch is the first vessel that comes off is the innominate artery, right? That gives off the right subclavian and the common carotid artery. Then you've got the left common carotid artery that comes directly off the arch. And then you have the left subclavian artery, okay? And so when it comes down, this is the thoracic aorta. And then as you come down further, you've got the visceral vessels that go to the celiac trunk, the superior mesenteric artery, the inferior mesenteric artery. And between the superior mesenteric artery and the inferior mesenteric artery, you have the renal arteries. As you can see here, the renal arteries are present. And then the bifurcation of the aorta, left common, right common iliacs. And then you got the internal iliacs and you have the external iliacs. So the people that I see usually have an affection of their distal aorta or even the infrarenal aorta, and then it affects the iliac arteries. And then infrainguinal vessels, the superficial femoral artery, you've got the profunda femoral, which is the main vessel that keeps everything alive, because if the superficial femoral artery gets blocked, you've got flow coming through the profunda femoral, filling geniculate collaterals that go beyond the areas of obstruction. Usually the obstructions in the SFA are at the adductor canal level. So when you have the superficial femoral artery behind the knee, you've got the popliteal artery, and then the vessel divides. It divides initially into 2. It divides into the anterior tibial, as you can see right here, and you've got the tibioperineal trunk with the division of 2 vessels, which is the posterior tibial and the perineal artery. Okay. Any questions so far? No. And then in the upper extremity, you've got obviously the subclavian arteries left and right. And here on the left side, you've got the axillary artery where it turns right under the axilla. And then you've got the brachial artery, which then gives off some branches and then divides into the radial artery and the ulnar artery. The ulnar artery is usually the dominant vessel. It's actually the dominant vessel. The accessory is a radial artery. And then you have an interosseous vessel as well. And then you have filling of the hand through the connections of the arch vessels. You also have an arcuate artery in the foot that connects the anterior tibial dorsalis pedis to the posterior arterial circulation, etc. You can see here the posterior tibial artery in this section here, the anterior tibial artery, and then the dorsalis pedis filling the arch, etc. Okay, so that's a kind of a summary of your vascular anatomy. So patient comes to your office and he complains of leg, or he or she complains of leg pain. So you have to have a differential, right? You have to, first of all, you have to think vascular, you know, you got to make sure the pipes are okay. Our arterial blood flow, is it going down there? Is the venous return adequately? And the way these patients present themselves, you can actually tell whether it's an arterial condition or a venous condition. Does anybody want to jump in and describe what an arterial leg, a leg that's lacking arterial blood flow may look like? Let me see some names here. Carlos Caballero. A ver, Carlitos, dígame usted, cuando viene un paciente con un problema arterial en la pierna, ¿cómo cree que esa pierna se va a presentar? How is that leg going to look like?
Esa pierna se va a ver pálida y se va a sentir algo fría de repente.
Okay. Bueno, no es tan mala respuesta. It could be okay. Cuando uno tiene un problema arterial, ¿no? Tenemos que pensar que el problema arterial o es agudo o es crónico. Cuando el problema arterial es agudo, lo que pasa es que la arteria se ha obstruido en forma aguda. Entonces el pie, the foot becomes pale, okay? And there's pain in the foot. If the foot is constantly red, and you take that foot and you elevate it and it blanches white, then that tells you that's probably a chronic condition. That's called pending rubor, okay? Pending rubor. Es un rubor que se presenta cuando el paciente está con la pierna colgada. Okay, that's pending rubor. So vascular could be a pale or it could be a bright red, depending on the chronicity. So let's say this is a chronic condition. Es un problema crónico. Un paciente que viene, que uno está examinando a ese paciente y ve que el pie está rojo mientras el paciente se está sentando. Se ve bien, rojito, bonito, no se ve tan terrible, pero el paciente dice, me duele la pierna en la noche y tengo que colgar la pierna de la cama porque eso es lo único que me alivia. Y doctor, duermo toda la noche sentado porque no puedo dormir plano. Esos pacientes que tienen enfermedad periférica vascular crónica con lo que se llama isquemia crónica, no van a tener el pie generalmente rojito porque no está llegando flujo arterial. Lo que pasa es que las arteriolas pequeñas se van dilatando, haciendo que se congestione el pie. Y eso es what's called rubor, pending rubor, ¿ok? Si viene un paciente y tiene la pierna hinchada y se ve violácea, está congestiva, ¿no? ¿Qué es lo que ustedes van a pensar? André Acuña, ¿qué crees tú, André?
Que la causa es venosa.
Correcto. Entonces hay un problema del sistema de alcantarillado, ¿no? Se ha obstruido. Entonces se está retrasando todo el flujo. Se está congestionando el flujo porque no hay salida de afuera. Hay entrada, pero no hay salida. Entonces, so you guys see the difference, right? Between arterial and venous. A patient that comes in with arterial, if it's acute, the patient's going to have a pale leg and the patient's going to have coolness, pain, right? It's going to have there's four things of acute limb ischemia. And it's pain, rubor, poikilothermia, which is coolness, right? Paralysis, you know, that's another cause, right? Parálisis, una pierna aguda puede tener parálisis, hay palidez, hay dolor, hay Se siente fría la piel, ¿no? The 4 Ps of acute limb ischemia. Eso es todo un topic. That's a whole different topic to discuss, acute limb ischemia. But I'm trying to give you guys an understanding of your differential diagnosis, okay? So arterial, the tap water is not getting to, the destination. You're not getting flow of fresh blood down there, okay? And then the venous flow is all the waste, all the blood that's been deoxygenated, all the nutrients have been pulled out. It's dumped into that sewage system that we know as the venous system, and it goes through that leg. And if there's an obstruction, the whole leg swells up, right? And then that whole leg can swell up to a point where the pain could be, is similar to claudication pain, but this time it's venous claudication. There's no outflow. Okay, that's another topic of discussion, which is quite interesting. And then in your differential, you have to think of musculoskeletal, right? Maybe this patient's got arthritis. Maybe, the pain between arterial conditions and musculoskeletal conditions are very different. The patient may say, okay, doctor, I have leg pain. And when the leg pain it starts after I walk about a block. And my calf gets tight and it's uncomfortable and I have to stop. And then the pain subsides and I can walk again. That's your classic arterial claudication. Versus a patient that says, you know what, doctor, I'm sitting for a long period of time and I stand up and my leg hurts and it constantly hurts until I stop. So really there's no increase in demand of muscular metabolism, right? The muscles are not demanding more oxygen. They're not demanding more nutrients. And so the guy's got pain all the time. So you have to investigate a musculoskeletal issue that could be arthritis or polymyositis or something associated to the musculature, not necessarily a arthritic joint condition. Neurogenic pain is also very important. A patient with spinal stenosis, degenerative joint disease of the spine. Neurological pain also presents very similar to musculoskeletal and arthritis. And it's important when you guys are doing your differential diagnosis that you guys discuss with the patient their symptoms and if they had lower back issues or back surgeries, anything that could be associated to the back. And you guys know now how to diagnose sciatica, right? Yeah, Yanibeth, ¿ustedes saben hacer un diagnóstico de ciática? ¿Entienden cuando tienen una lumbalgia o un problema del nervio ciático? Eso hasta a los jóvenes les afecta. A veces cuando hay un poco de herniación de disco, el nervio ciático se afecta. And that herniation of the disc can cause the sciatic
Excuse
nerve
me, male needs your attention.
to have issues. All right, let me see what this thing wants. Okay, so any questions so far in your differential diagnosis? ¿Alguna pregunta? Wow, tenemos hartos estudiantes, me alegra. I got a lot of students watching me. All right, so let's ask the future cardiothoracic surgeon. Well, actually, Enrique wants to be an oncological specialist. Enrique, what do you think? Any questions so far?
No, está claro.
Okay, good. All right, so let's go back to now the symptoms. So we talked about symptoms as we went along there. And so pain with walking, usually uphill versus flat areas. People can tolerate better walking flat than going uphill. The pain when you have disease in the superficial femoral artery or the SFA, that disease will be presented in the calves. If you have disease higher up in the iliac vessels, the thighs can be affected if the blockage is in the common iliac arteries because you're not getting blood flow into the internal iliac arteries. And that would be in the buttocks, in the gluteal area. The thighs can also hurt when the external iliac arteries are occluded. So depending on the level of the disease, you're going to have the symptoms for these patients, okay? There is a condition called Leriche syndrome. Have you guys heard of that? Eric Cedeño, ¿has escuchado del síndrome de Leriche? Ok, el síndrome de Leriche es un síndrome vascular y pues va asociado con claudicación de los glúteos y también con impotencia porque el paciente no tiene circulación que está entrando por las ilíacas internas. Okay, so you guys can look that up. Lariche syndrome. So it's very consistent to the pain, and it's always associated to locomotion. Okay, no porque estamos locos, but because there's locomotion, right? There's movement and activity. When your demand increases because you're walking, that demand can be restricted because of a lack of good blood flow. So it's reproducible, it's consistent, it's reproducible, it resolves with standing or sitting, and no pain when they're laying down, okay? Or when they're resting. Now we talk about rest pain. So this is pain that often happens at night or when you're laying flat, and it's more distal. It's usually affecting the feet. This is the patient that I told you that needs to hang the leg off the bed. When they hang the leg off the bed, guess what happens? Gravitational pull of the earth pulls that hydrostatic pressure down, allowing the blood flow to get down to the tissues better, okay? And that's why those vessels in the foot are so dilated, because they want to, I saw that, Liz. I saw you yawning. Hope you're not getting bored, Liz Mendoza. Okay, all right. I don't know if Liz heard that, but I wanted her to laugh a little bit. All right, anyway, so it's relieved by gravity and also by standing up and trying to walk around. So inspection is very important. You guys remember your semiología, right? Your clinical examination. ¿Ya han pasado ustedes la clase de semiología?
Yes.
Yeah. ¿Son estudiantes de cuarto año o tercero?
Quinto.
Quinto, bueno, ya, pues ya ustedes son casi doctores. Ok, entonces hacemos una inspección de la extremidad, and in that inspection of the extremity, you look to see if the guy still has a hairy legs. Hopefully the ladies have shaved their legs, but if they're hairy ladies, maybe, they don't shave, and you can see the lack of hair on their legs. That's one sign of vascular insufficiency. You assess for capillary refill. Everybody remembers capillary refill, right? Less than 2 seconds. Now, if you see the capillary refill greater than 2 or 3 seconds, then you're suspicious that they're not getting enough blood flow. The coloration of the skin, is it ruberous or is it cyanotic? Is there swelling or edema? How are the nails? Usually the nails in patients with PAD are very thickened. The ridges are thickened. So you notice that these patients, because of the lack of good oxygenation, there is metamorphosis of the nails, and the nails become very thickened and ugly looking. Not necessarily from fungal infection. So also remember your differential diagnosis with fungal. What does the foot look like? How's the skin? Are there any ulcers, etc.? So you look for the architecture of the foot to see if there's any deformities, calluses. Is there cellulitis? Is there an infection? Are there ulcers? Are there signs of gangrene? Okay, so this is all on your inspection. Palpation, you palpate the patient's extremities looking for pulses. You examine them sitting, you examine them supine. And then these are the clinical findings suggestive of peripheral vascular disease or peripheral arterial disease. Decreased pulses in the femoral distributions, right? Bilaterally, popliteal, dorsalis pedis, and posterior tibial. It's also very important to have a little Doppler. Those little Doppler helps us analyze the Doppler sounds, and the Doppler sounds can be monophasic or can be multiphasic, either triphasic or biphasic. The classification now, or the denominations, change. Before we would be very, very discriminative versus the two different type of waveforms, the triphasic waveform versus biphasic waveform. Now we just say, multiphasic, because as you get older, your triphasic waveforms start to change and they just become biphasic. So it's either monophasic or multiphasic. Then you look and you assess for muscle atrophy, hair loss, nail changes, as we talked about, and dependent rubor, ulcers, and gangrene. So the classification of PAD, there's two guys that were in competition to create a classification. Both of them are very good. One is the Fontaine classification, and the other one is the Rutherford classification. As you can see here, one is in stages and the other one is in grades and categories. On the Fontaine classification, a stage 1 is patient with vascular disease, but is completely asymptomatic, okay? They have evidence of calcification in their vessels, but they don't have any symptoms of claudication yet. So the 2A classification, they have mild claudication. So this is somebody that can walk probably about 3 or 4 blocks, and then they get tired and they have to rest. A 2B is moderate to severe claudication. So this is someone that can walk maybe 1 to 2 blocks and will have to stop and rest. Type 3 is ischemic rest pain. This is an individual that is laying down in his bed at home, watching Netflix, and his foot's hurting and he's got to hang the foot off the bed. All right. And then you've got the stage 4, and this is the bad one, right? Because now you're talking about critical limb ischemia or limb-threatening ischemia, right? So in this case, the patients have ulcers and they have or gangrene. This is a patient that we have to jump on quickly to revascularize that limb, or that patient's up for an amputation. The Rutherford classification goes from grades 1 through 4, and grade 0 is asymptomatic, okay? So Fontaine discriminates these patients even if they have a small amount of plaque in their arteries and they're completely asymptomatic, gives them a stage 1. But Rutherford said, no, this is going to be a grade 0 because they're completely asymptomatic. I think I like the Rutherford classification better. Grade 1, mild claudication, grade 1-2, moderate claudication, grade 1-3, severe claudication, and then we go to grade 2, which is ischemic rest pain. And then grade 3, minor tissue loss, and grade 4, ulceration. Okay, category 1 through 6, or grades 1 through 4. Any questions so far? No? Okay. All right, so now we're going to go into a classification that we talked about earlier about acute limb ischemia, okay? This is the one where Carlos Caballero said, yeah, the foot is probably pale, you know? And here's your acute limb ischemia classification. So a patient that comes in with a Rutherford classification or a category 1 is a patient that comes in with a viable leg. It's not no immediately threatened limb. And these are the findings, and these are the Doppler signals. The sensory loss, none. Muscle weakness, none. Arterial signals are audible, and venous signals are audible on Doppler, okay? A class 2 acute limb ischemia is a threatened limb. All right. And this is either a 2A or a 2B. 2A would be marginally threatened, which is salvageable if we promptly assess. Sensory loss is minimal, but they do have some sensory loss. There's no muscle weakness. And the Doppler signals are often inaudible. So you're not going to hear any Doppler signals, but the patient doesn't have profound ischemia yet. And there is audible venous flow. When you listen to a venous flow on Doppler, let me see who I can pick on right now. Let's see who's paying attention. Brian Robles. Brian, what do you think that you're going to hear on Doppler on the veins? What type of flow would you hear in the venous flow, venous circulation?
Ahorita no recuerdo. Sé que el arterial es bifásico.
Claro, el arterial normal es trifásico y la vena es un flujo continuo. Es un flujo continuo como si fuese monofásico. Es continuo. Entonces uno puede escuchar el flujo de la vena. And if you take the foot and you squeeze the foot, you can actually augment the venous flow. Okay? You can't do that with the arterial blood flow. So the 2A is marginally threatened. A 2B is immediately. This is a patient that you need to do something about really, really quick. Salvageable with immediate revascularization. Sensory loss is more than the toes. So not just the toes are affected, but now the foot's affected. The heel is affected. The dorsum of the foot is affected. Muscle weakness is present. It's either mild or moderate. So they're not going to have the same strength they have of the opposite leg. Arterial Dopplers are usually not, you won't hear them. And the venous flow, you may be able to hear it. Now, a category 3, acute limb ischemia. This is when the patient has profound ischemic changes and it's irreversible. Major tissue loss or permanent nerve damage. You don't want to revascularize a dead leg, okay? They have profound anesthesia, profound paralysis, and you don't hear venous or arterial flow. What do you guys think would happen if you tried to revascularize a dead leg? Let's see, who's paying attention here? Where is my student that was yawning? I'm going to ask her. All right, ¿dónde está la estudiante que estaba bostezando? A ver, Hágame recuerdo. ¿Quién es esa joven? No quiere hablar. Qué barbaridad. Okay, bueno, let me see. Let me pick somebody here. Sally Wong. Okay, Sally. Dime. Si tratamos nosotros de revascularizar una categoría 3 de Rutherford, what do you think is going to happen if you try to, when you try to play Jesus and you try to bring Lazarus out of the tomb? You got a dead leg here. What do you think is going to happen? I don't hear you. Nothing? No?
No, no sabría decirle, doctor.
A ver, ¿quién me puede responder? ¿Qué sería, qué se les viene a mente una pierna revascularizada que esté en proceso de necrosis? Si nosotros revascularizamos una pierna necrótica o una pierna que está profundamente dañada, más de 6 a 12 horas sin circulación arterial, lo que pasa es que ya está empezando a haber muerte celular. ¿Qué es lo que pasa cuando hay muerte celular? ¿Qué es el elemento? ¿Qué es el mineral que se va saliendo de la célula que puede causar paro cardíaco? Son de 5º año, changos, deben saber esto. You guys should know this. What happens?
El potasio, doctor.
Ah, está. ¿Quién respondió?
Enrique.
¿Quién respondió? ¿Enrique?
Sí, sí,
Ok.
doctor.
Bien. Ya, buena respuesta. Correcto. El potasio, cuando hay muerte celular, potassium is spilled out. Okay? So if you bring back the circulation, that potassium is going to wash back into the circulation. And what's high levels of potassium going to do to your heart? It's going to stop your heart from beating, right? Enrique, ¿quieres explicar a la clase cómo funciona eso?
Más o menos recuerdo que era producía arritmia en la fase 4 del latido cardíaco.
Correcto. Cuando uno quiere ir a matar a su perro, ¿no? Con el veterinario, ¿qué hacen los veterinarios para hacerlo dormir al perrito? Le dan una inyección de potasio puro, porque eso le va a causar paro cardíaco. Por eso es que cuando un paciente le hacemos los estudios de químicos, ¿no? Y vemos que los niveles de potasio están elevados, pedimos un electrocardiograma y lo que queremos es agarrar el potasio que está circulando y volverlo a meter a la célula. Entonces le damos al paciente insulina, ¿no? Para hacer ese shifting. Y además le damos calcio, porque el calcio ayuda a estabilizar la membrana. ¿Se acuerdan su fisiología médica? Recuérdense fisiología médica, nada más. La despolarización y repolarización de los músculos, ¿ok? Ok, bueno, ya no los voy a torturar con eso. Además del potasio que está siendo puesta dentro de la circulación sanguínea, también tenemos rhabdomiólisis. ¿Y qué va a pasar con la rhabdomiólisis? Va a ser un paciente una insuficiencia renal aguda porque estamos metiendo tanta cantidad de proteína, ¿no? Mioglobinuria, que vamos a causar necrosis tubular aguda. Y eso va a causar al paciente que entre en una falla renal. Entonces, nunca jamás deberíamos revascularizar una pierna que esté como esta, ¿ok? Porque matamos al paciente. Y si sobrevive, matamos los riñones. ¿Entendido? Ok, entonces habíamos hablado de las 4 P's, pero existe una quinta, ¿ok? These are the 5 P's of acute limb ischemia. Pain, pallor, paresthesias, pulselessness, and paralysis. Paralysis, you understand. Pulselessness, you can't feel a pulse. Paresthesias, you have paralysis or just tingling. or complete numbness. Pallor, the patient, you feel them waxy, you know, they're pale, etc., and then pain is all of a sudden. So how do we test patients with vascular conditions? And we test them. We can, if they come into the emergency room, you can do a quick ABI, an ankle brachial index. Have you guys done an ankle brachial index, Enrique, in your practices in school?
Sí, en la práctica clínica.
Okay, good. So the ankle brachial index is a pressure measurement from the brachial artery and then one from above the ankle. And what we do is we divide the bottom number by the top number, and then we get a value. And that value usually, if it's 1, it's normal. If it's less than 1, you know, it's still normal if it's 0.9 and above. And we'll go through this. You guys will see this. Segmental pressures are also nice to have because you can measure pressures from the thigh all the way down to the ankle. Doppler waveform analysis is important, telling you if it's monophasic, biphasic, or triphasic, and that usually goes along with pulse volume recordings. Segmental pressure principle in a normal individual in a supine position, ankle systolic pressure is greater than or equal to the brachial pressure, okay? That's in a normal individual. Ankle brachial index, or ABI, you do bilateral ankle pressures divided by the higher brachial pressure number. Dorsalis, this is the dorsalis pedis that you can see on the right-hand side with the Doppler probe over the top. It should be easily compressed, and it's not difficult to find if you know your anatomy. The posterior tibial is a little harder to compress because you have the medial malleolus there, but it actually is easier to locate with your fingers. These are examples of segmental pressures. All these different color bands are pressure cuffs that are placed on the patient. And you can see that here's the brachial artery systolic pressures. And down here you have the systolic pressures in the foot and also at the level of the ankle. And here are these numbers represent the numbers of the arterial of the indice. So over here, a 0.92, 0.98, PTDP, these are normal values. Anything above 0.9 would be considered normal, okay? So here's your resting ABI values. And I mean, resting is very important to understand because you can do an ABI with a patient on a treadmill. If the patient's on a treadmill walking for about 10 minutes, and then you get an ABI, these values can actually go down, indicating that there might be actually a blockage along the arterial tree in the limb. So this is a normal ABI, which is usually 1 or higher. Now, you can have very high ABIs in patients with diabetes because of medial intimal wall calcification. And that's something else I'll explain to you guys. But anything less than 0.9 is abnormal. Less than 0.8, probably the claudication is associated to that. Less than 0.5. That means that there's multi-level disease or a long segment occlusion. That could mean that the superficial femoral artery is completely occluded. And then less than 0.4, this is when the patients will actually have ischemic rest pain, okay? Here's the bane of pressure measurements. Calcific medial sclerosis in patients with diabetes will throw off our ankle brachial indices. Chronic steroid therapy, renal dialysis patients who are on renal dialysis. What do you think happens in these individuals with renal dialysis? Why do they get calcific medial sclerosis, even if they're not diabetics? Let's see who's paying attention here. Luz Villarruel. Luz, ¿qué te parece esto del diálisis renal? ¿Cuál sería el mecanismo por qué los pacientes en diálisis renal hacen una calcificación media, una esclerosis calcífica media?
Por el mismo proceso inflamatorio que ellos ya están desarrollando.
Puede ser, pero ¿qué es lo que pasa durante el proceso de diálisis? ¿Qué mineral se va extrayendo durante diálisis que hace que las paratiroides empiecen a funcionar más?
El calcio.
Correcto. Entonces, estos pacientes tienen una hipercalcemia terciaria, ¿no? Que está aumentando los niveles de calcio, y eso hace que se acelere el proceso de aterosclerosis, endureciendo las arterias. Eso es importante entender eso, ¿ok? Pacientes obviamente mayores, pues que tienen endurecimiento de las arterias o just advanced atherosclerosis due to aging. So these individuals will have segmental pressures that are unobtainable or excessively high. That's what we were talking about earlier. If these patients, and these patients, what we like to use is toe pressures, all right? And the toe pressure, if it's a toe pressure greater than 40 millimeters of mercury, that's going to be favorable for tissue healing, especially in diabetics. If it's greater than 20 millimeters of mercury, for tissue healing in non-diabetics. This is a little extra thing that I put in there. But toe pressures are kind of the savior for us when we're trying to determine if the patient actually has significant peripheral arterial occlusive disease. And why toe pressures? Because in patients with diabetes, actually the toe vessels are preserved. That's why you can see these patients will have rubor, pending rubor, because the smaller vessels are still intact versus the larger and medium-sized vessels, okay? So a toe brachial index can help us determine if the patient actually has adequate flow all the way to the toes. And that's when you have an abnormal ABI higher up that's elevated. Let's say you have an ABI that's 1.7 and you're like, oh my God, it's so high. It's not because it's normal, because it's abnormal. You can't compress that vessel because it's so hard. So that's why you get a higher value, all right? All right, so this is the TBI chart, and these are the ranges on the left-hand side. So normal is greater than 0.7 or 0.7 and greater. Anywhere from 0.5 up to 0.7, it could be mild. If it's 0.35 to 0.5, it's moderate. If it's less than 0.35, moderate to severe. And that's with a toe pressure of 40. And if it's less than 0.35, with a toe pressure less than 30 millimeters of mercury, this is severe. So this kind of helps us. This is an additional tool that we can use on those patients with end-stage renal disease or diabetes, or chronic steroid therapy that can help us determine what we need to do for that patient. So this is a Doppler waveform analysis of a normal lower arterial waveform, which is considered triphasic. If you guys took your Doppler and put it on your radial artery right now, you could actually see this type of waveform. It's got 3 little bumps. The first one, the second one, and the third one, right? This is a triphasic Doppler signal. And here is an abnormal waveform. So you lose the triphasicity and the amplitude is dampened. You can see the difference between this common femoral artery and this superficial femoral artery, right? So it's a slower upstroke versus a normal upstroke. And then the amplitude is definitely dampened and it is widened. All right, so that's the difference between the two. This is the ABI again. We're not going to go through that one. Physical exam findings suggestive of PVD. Obviously, we understood all of that. Here's so when we're coming up with a diagnosis for PVD, you start out with minimally invasive studies first, right? Your clinical examination, your Doppler signals, your inspection, et cetera. And then you do a duplex ultrasound. Now, the duplex ultrasound gives us a lot of information that pulse volume recordings won't give us, okay? Or an ABI itself. The duplex ultrasound shows us velocities, color flow through the vessel. It lets us understand the anatomy of the vasculature, what the characteristics of the wall of the vessels are, if they're calcified, non-calcified, if there's thrombus, if there's plaque, what type of plaque there is, because not all plaque is created equal. You've got very calcified plaque, which could be heterogeneous mixed calcium with soft plaque. You can have very calcified coral reef-like calcifications. All of that can be seen on duplex ultrasound. But the most important thing is being able to measure the arterial blood flow through these vessels. And that's how we identify where the blockages are. Okay, so when you're looking with an ultrasound and you're probing all the way down an extremity, you can get pressures you can actually get velocity measurements in different segments. So if you're looking at, for example, the common femoral artery into the proximal suprafemoral artery, and you see a velocity that goes from 50 to 250, what do you guys think is going on? Let me see who can I can ask this. Carla Guerra. Carla está bien atenta, así que ella me va a responder. Carla, ¿qué tú piensas si tú ves una elevación de la velocidad del flujo de sangre por el dúplex en una arteria? Que como dije ahí, de 50 a 250. ¿Qué es lo que está pasando en esa arteria?
Está más obstruida.
¿Por qué está obstruida? ¿Cómo sabemos eso?
Porque aumenta la velocidad.
Exactamente. Nosotros toditos hemos regado el jardín de nuestras casas, ¿no ve? Tal vez todos, no, tal vez no. Pero cuando agarras tú la manguera y le pones el pulgar ahí al final de la manguera y aprietas el pulgar, ¿qué pasa con el chorro de agua?
Aumenta.
Aumenta la velocidad, ¿no? Ahí puedes chisguetearle a tu vecino, ¿no? Y en carnavales le puedes mojar con la manguera usando tu pulgar porque estás aumentando la velocidad con la que sale ese chorro de agua. Pero no lo vas a poder empapar, lo vas a apenas mojar, ¿no? Porque lo estás haciendo un roceíto nada más. Entonces, lo que pasa en las arterias es lo mismo. Esa arteria se va achicando, entonces el flujo de sangre va aumentando, ¿no? No, va aumentando la velocidad de la sangre. Entonces, aumenta la velocidad, pero la cantidad que está pasando al otro lado es poco. Y eso es lo que ellos sufren. That's where the lack of amount of blood flow is affected, because on the other side of that narrowing, they're not getting enough pressure of blood into the tissues, okay? So yes, Dopplers will give us a understanding of how obstructed a vessel can be. Now, if you're doing a Doppler and you don't find any velocity, you know it's completely obstructed. But if that velocity is really high, 300 or 400 centimeters per second, you know something's going on there, because that shouldn't be that. It should be less than 180 centimeters per second. It should be anywhere from like 50 to 100, you know, but there shouldn't be any shifts in velocities. It actually starts to drop off because you're increasing, your vascular resistance starts to decrease. So it goes from 150, goes to 80, to 60, 50, et cetera, until it gets down to your toes, okay? All right, so let's keep going here. All right, so what you guys are looking at over here on the right-hand side is an angiogram, and this is a popliteal artery. You can see the joint, right, the knee joint. And you can see that this is the popliteal artery. This is the P3 segment that's just below the joint space. This is the P2 segment, and up here near the adductor canal or below the adductor canal is the P1 segment. And the first vessel that comes off here is the anterior tibial. And you can see a little blockage here, right? But it looks all ratty. So this is the more significant stenosis. And when you come down the tibioperineal trunk, there's no posterior tibial. The posterior tibial, there's a remnant right here of where the posterior tibial was. But the TPT trunk is diseased, and the perineal artery is also severely diseased. And this perineal artery here has got some very severe stenoses, right? So that is an angiogram. And then the other thing we can use is an MRA or a CT angio to be able to discern the flow. So this is a normal arterial duplex. That's a normal arterial waveform. And we can get velocities, peak systolic velocity of 89.4 centimeters per second, and diastolic velocity is 0. That looks pretty normal. Here is an abnormal duplex. And when you see this, guess what? You get an elevation of your velocity. So you see this high peak up here. This is reverberation. This is the same thing. The waveform stops right here where my arrow is. So the velocity is 327 centimeters per second, and the end of diastolic velocity is 57. But if you see this velocity, you know, on this, I'm sorry, this is where it ends right here, and this is where it begins. So 327 centimeters per second, and then it drops down to 57. Okay. But before that, it was probably lower, the velocity. So Anything above 180 centimeters per second is considered abnormal. All right, so this is task 2 classification. This is changed now because we've got a more complex classification, but task came out with this classification for distal aortic and iliac artery stenosis. Guys, give me 1 second. 1 second here. Today's the 13th or the 14th for me? ¿Hay alguna pregunta hasta ahora, chicos? ¿No? ¿Ninguna pregunta? Okay. All right. So the task classification, you've got type A lesions, which can be unilateral or bilateral stenosis of the common iliac arteries. Unilateral or bilateral single short segments less than or equal to 3 centimeters stenosis of the external iliac. So this is a type A lesion from the task classification. A type B lesion is a short less than or equal to 3 centimeters stenosis of the infrarenal aorta. So this is the renal arteries, and this is the stenosis below. Or you can have a unilateral common iliac artery occlusion. You can also have a single or multi stenosis totaling about 3 to 10 centimeters involving the external iliac artery, not extending into the common femoral artery, which would be down here, or a unilateral external iliac artery occlusion, not involving the origins of the internal iliac artery. No les voy a aburrir con esta clasificación. This is a classification that helps us guide us to what type of intervention we can do. A lot of these interventions now, for example, this type C lesion, we used to do aortal bifem for, because these lesions we deemed that were completely occluded, and reconstructing these would be very difficult. Sometimes it is very difficult, but we try endovascular first to cross wires through here and lay stents in here to reconstruct this. If we can't do that, then we'll go in and we'll do an aortal bifem. These lesions like this, for example, are all treated endovascular-wise. The total occluded lesions like these lesions are the lesions that we try to tackle endovascular-wise initially, and if it works, great. If it doesn't, then we opt for a more aggressive open surgery. This is the task classification for the superficial femoral artery. You've got type A, type B, type C, all the way down to type D. So this is based on the length of the occlusion. If you have a single occlusion that's less than 5 centimeters in length, it's a type A. If it's a single occlusion less than 5 centimeters, but heavily calcified or has multiple occlusions, each less than 5 centimeters, or a single occlusion less than 15 centimeters, you consider a type B. If it's greater than 15 with multiple occlusions, it's a type C, and a type D is greater than 20. So a lot of my patients that come here with limb salvage are patients that are completely occluded, greater than 20. Then we have how do we treat these patients? Well, first thing is risk factor modification. Medical therapy is the first line. When somebody has a patient with PAD, these patients, you don't want to aggressively treat them yet, because you need them to reform themselves. They come in smoking, they're poorly controlled diabetics, they have hypertension. So you have to give the patient time to adjust, to understand their disease, to educate them, to put them on a rehabilitation program, get them on a walking regimen. So stop smoking is the first thing if they're smokers. Walking programs are very important. They need to walk for 30 minutes to an hour every day. Even if it hurts, they should walk, stop, and then move on. Pharmacological therapy with Platol is or silostazol is something that we use very frequently. There's also pentoxifylline, which we also give these patients. There are several other things that we can do along with antiplatelet aggregants, either a baby aspirin, or we put patients on Brilinta, or on Plavix, which is also known as clopidogrel. Statins these days for patients with PAD and hyperlipidemia, we're very aggressive with statin management. Now the indications are high dose atorvastatin, usually 80 milligrams a day. We continue risk factor modification. Risk factor modification is essentially getting them to walk, making sure that their blood pressures are controlled, their diabetes is controlled, that they have better eating habits, et cetera, to improve their overall outcome. Foot care, taking care of their feet, moisturizers, adequate footwear that's not causing compression of the tissues that are not having good blood flow. So medical therapy, the next option is open surgery. About 20 years ago, a lot of these patients were managed with open surgery. Nowadays, we do a lot of endovascular repair. As you can see here, this is a description of a fempop, and you're seeing how we're anastomosing a greater saphenous vein on top of a common femoral artery. Surgical revascularization, aortoiliac. So the aortoiliac or aortobifem surgery actually has excellent outcomes when done well, and the patency rates are pretty good. The mortality, though, operative mortality is about 3.3%, and the perioperative mortality is morbidity, which means complications, et cetera, is about 8.3%. Okay, this is from JVS of 1997. Angioplasty of the iliac arteries. This is when we start doing iliac stenting, this is only angioplasty alone without stenting. So these are the different authors, and the technical success rate, as you guys can see, is pretty good. I mean, the best is Bloom's report in 1993 of 98% technical success rate. So 71% in the first 50 patients, 93% in the second 50 patients of this study. All our techniques in endovascular surgery have evolved significantly. We don't just do angioplasty anymore. We also we do stents. And as we started seeing Dr. Palma's reports in 1992 of his stent patency, our 1-year patency rates were 92% compared to only just angioplasty. Sullivan reports in 97, 84% in 2 years. So it's great. We've evolved. We have better techniques. It's not just angioplasty, putting a balloon in there and opening up the vessel, but putting a balloon in there and scaffolding that vessel so we can have increased blood flow. So angioplasty alone versus stenting. There was just a limited data back then in terms of that, but the 4-year patency for stents was 94%. The 4-year patency for angioplasty alone, 69%. So if you're a patient with PAD, you would probably want your surgeon to do a stent. Here is a very, very drastic picture. And this is a picture where you can see a distal bypass from the aorta down probably to the left common femoral and crossing over, or maybe it's just feeding the left leg. But this is like the worst case, that you can see. The common iliac arteries are gone. You can see remnants of calcification throughout the common iliacs. You have this huge, large sacral vessel that's actually, this is probably the inferior mesenteric artery that's still alive, feeding through collaterals. But this is kind of a horrific picture. I just wanted to share that with you. But you can get through these lesions like this, where you can access the right common femoral artery, go through all of this all the way up, and you can reconstruct that whole thing with angioplasty and then stenting. Here is kissing stent techniques with 2 stents on each side of the common iliac arteries. And then look. All of a sudden, you have reconstructed the distal aorta on a very, very nasty, heavily calcified vessel. So this is what we do these days, instead of having to open up the patient. This patient will have a reconstruction in a day, within hours, and then go home, and they're walking and they're comfortable. Here is a summary of the aortoiliac segment, focal disease. You can definitely treat with endovascular therapy. The more complex disease, If the patient is good risk, you can do a surgical revascularization. If the patient is poor risk, you can do an endovascular. Now, let's also remember that the open surgical approach actually gives you a longer lasting result, but it also increases the perioperative morbidity by 8.3%, and the mortality is about 3.3% of that surgery. Remember, you're opening up the patient's abdomen, you're exposing the retroperitoneum, you're individualizing the vessels of the distal aorta, you're exposing the groins, et cetera. There's a lot of manipulation, there's a lot of aggression, to do this revascularization. The surgeons that have the greatest success are the ones that don't take very long to operate these patients, and that they don't have the patients opened up for too long of a period. These are the outcomes of FemPop treatments, 5-year patency with PTA for just stenosis, 68% 5-year patency rate, which is not terrible. Occluded vessels that are treated with just angioplasty alone, 35%. A FemPop bypass, 80%. A FemPop bypass above the knee with PTFE, which is a synthetic graft, 75% 5-year patency, and a below the knee with PTFE, 65%. So your vein is always better for a FemPop below the knee, and also for above the knee, but you can get away with above the knee synthetic graft, which gives you a pretty good patency rate in 5 years. But your vein is always good. If you're going to do a bypass surgery in a patient with severe claudication and has a non-endovascular approach, then if you elect for this option, you would do a vein bypass. Now, how do you select a patient that's going to have an endovascular approach versus an open approach? So we try to limit our bypass surgeries to patients that are healthier, younger, and that need a result that's going to last them for the rest of their lives. So if I have a patient that comes in, he's 50 years old, 55 years old, generally in relatively good condition except for a blockage in his artery, he stops smoking, then a bypass surgery would probably be a good option. However, those patients don't want to have big incisions in their legs. So many times they'll request for us to do an endovascular surgery. But if you do an endovascular surgery and that endovascular surgery fails in that young patient, then you still have the option of doing a bypass. Okay? Any questions? ¿Alguna pregunta hasta ahora? ¿No? Entonces, pacientes jóvenes, es mejor tratarlos con un bypass de vena que pacientes no jóvenes, ¿no? Que tienen el mayor riesgo. Recuerden que un bypass, una cirugía de bypass necesita anestesia general. Esa anestesia general puede suprimir al paciente en el sistema cardiovascular, causarle un infarto de miocardio o demás, si el paciente está predispuesto a eso. El bypass con vena es el mejor, el más duradero, ¿no? Porque no estás poniendo ningún tipo de prótesis sintética. Pero si tienes que usar una prótesis encima de la rodilla, funcionan bien y es muy comparable el resultado de los 2 a 5 años, ¿no? Vena versus prótesis. Debajo de la rodilla con prótesis, el resultado cambia significativamente, ¿no? Entonces tenemos más o menos un 15% de diferencia que es significativo. Okay, este es un paciente with a adductor canal stenosis of the superficial femoral artery. You can see the profunda vessels here, and this is a kind of a short segment occlusion. This is a patient that would be a good candidate for an endovascular approach. So you see here, this is a balloon angioplasty of that segment, and just balloon angioplasty alone will give you a good result. Here is a patient with infrapopliteal artery disease. You can see this is the popliteal artery. This is P3, and the anterior tibial is completely occluded distally. And you have the TPT trunk here that's very ratty, very diseased. And you can see the perineal artery coming down, which looks like it's the primary vessel to the foot. And then you have the posterior tibial, which is severely diseased. This is a patient that probably has rest pain. You know, he's the one that is hanging the leg off the bed and has to stand up and walk a little bit so the pain can go away. This is actually after revascularization. You can see there's improvement of the flow in the perineal artery as well as the posterior tibial artery. So intravascular ultrasonography is kind of the the third view, the last view that we have to determine if a vessel is been treated adequately, and it also lets us see the vessel on the inside. So angiography gives us a two-dimensional view, and this is the third dimension. This is the third dimension that allows us to look inside the vessel and determine the size of the vessel, the area of narrowing, the stenosis, the quality of the plaque, and it helps us determine, what we need to do. This is a normal intravascular ultrasound. You can see a nice lumen. All the stuff that you see on the inside is flow of this. These are all red blood cells and white blood cells that are circulating through the bloodstream. And this is an artery that's, this is the normal size of that vessel, as you can see here. This is the media of the vessel. And the intima is all of this plaque. And this is how narrow that vessel is. And this is the view of the IVUS. This is actually the catheter itself. So you can see this is the catheter. It's a 2-millimeter catheter. Each little dot's a millimeter. Volcano is the company that we use now. It belongs to Philips, and these are the equipment that we have that run these different types of catheters that go down the extremity. Have Boomy sign that. So this is a femoral, popliteal, and tibial bypass summary. Focal disease, endovascular therapy works extremely well. For a more complex disease, if the patient is, again, good risk, surgical revascularization, poor risk, endovascular. Now, the beautiful thing about endovascular surgery is that if you have a 90-year-old patient, that comes to your office and is not a real good candidate for general anesthesia to get a bypass, endovascular surgery works very well because you can do these patients under local anesthesia, and that's it. You don't even have to sedate them. So the claudication, open surgery, bypass, tissue loss, endovascular therapy is now the mainstay. Okay, ¿alguna pregunta hasta ahora, jóvenes? ¿No? Esto es el nuevo centro que acabamos de construir en la ciudad de Charlotte. Es un edificio de 22,000 pies cuadrados. Todo el centro vascular está en el segundo piso. Y pues ojalá que algún día ustedes puedan hacer unas rotaciones con nosotros para poder tener esa experiencia de ver pacientes de cirugía vascular. A ver, Yani, ¿alguna pregunta?
No, doctor, todo bien.
Ok. ¿Qué más les gustaría saber de cirugía vascular? Enrique, ¿alguna pregunta?
No, doctor, fue bastante clara la charla.
Ok, perfecto. La cirugía vascular es muy importante porque el problema de enfermedad periférica vascular es algo muy significativo. Los pacientes que enferman que tienen grados bien avanzados de enfermedad periférica vascular, que terminan perdiendo las piernas, implica no solamente un estado emocional para el paciente, pero un estado de inhabilidad y dependencia que hace que ellos pues sean una carga para la sociedad en general, ¿no? Y nadie quiere ser una carga para la sociedad. La gente amputada, pues se los puede manejar bien, se les puede poner prótesis, se les puede hacer terapia para que ellos puedan tener vidas casi normales, ¿no? Pero también, pues si podemos evitar la amputación, y darles a ese paciente la calidad de vida que se merecen, pues ese es nuestro deber, ¿no? Como médicos, identificar el problema tempranamente darle una solución y pues permitir que estos pacientes puedan tener mayor longevidad de vida, mejor calidad de vida, teniendo sus extremidades. ¿Ustedes entienden conocen bien sobre el tema de aneurismas? ¿Les han dado algún curso de aneurismas? ¿O no?
Sí, bueno, en cirugía nos hablan un poco de los tamaños para operar y los factores de riesgo de aneurisma.
Ya, entonces un aneurisma de aorta cuando llega a 5 centímetros en la mujer o 5.5 centímetros en el hombre ya es un candidato para hacer una reparación endovascular. Muchas de las cirugías que hacemos hoy en día son endovasculares, pero también pueden haber situaciones donde tenemos que hacer una cirugía abierta. ¿Qué me está pasando con esto? A ver. Espérenme un segundo, jóvenes. Ok, mira, vamos a buscar otro tema. Estaba tratando de enviar estas. Claro que sí. Por eso es muy importante al paciente vascular hacerle un seguimiento bastante constante. Si digamos, yo opero a un paciente hoy día, ese paciente tiene que hacerse su seguimiento de ultrasonido dentro de una semana o dos. Y después que viene con el seguimiento después de 2 semanas, vuelve al mes. Y después del mes, vuelve a vernos a los 3 meses. Y si en 3 meses está bien, en 6 meses. Y por lo general, estos pacientes vasculares en 2 años empiezan a tener de nuevo formación de placa ateromatosa que tenemos que volver a reintervenir. La cirugía endovascular nos permite reintervenir estos pacientes cuando necesitamos reintervenirlos. Pero para reintervenir un paciente es importante hacer un seguimiento de estos pacientes para poder identificar algún cambio de las arterias. ¿Okay? ¿Alguna otra pregunta?
Y en el caso del estadio 3 de la clasificación de Rutherford, el manejo ahí sería que amputar la extremidad.
Exactamente. Si es una isquemia aguda de la extremidad, el manejo es amputación. Entonces, lo que nosotros haríamos es determinaríamos a qué nivel vamos a hacer la amputación. Si la extremidad inferior debajo de la rodilla está afectada y todavía hay circulación hasta debajo de la rodilla, no, pero no en la pierna, entonces sí podemos hacer una amputación debajo de la rodilla. Si la falta de flujo afecta completamente toda la extremidad, entonces tenemos que ver la posibilidad de hacer una amputación encima de la rodilla y eso mucho depende de dónde para la circulación. Puede ser una amputación bastante más alta o puede ser una amputación unos 10 a 15 centímetros encima de la rodilla. Pero siempre tratando de conservar la mayor parte de la extremidad.
Muchas gracias, doctor.
No, de nada. ¿Alguna otra pregunta? Enrique. Ok. Sería lindo que en otra ocasión ustedes puedan ver un caso en vivo aquí en Charlotte a través de Zoom que podemos coordinar, ¿no? Con el doctor Victoria. Sí, todo el mundo, pero está calladito, nadie me pregunta más. Espero que todo ha sido bastante claro y agradezco la atención de todos y me da pena que hemos empezado un poco tarde esta mañana. pero a veces hay cosas que son impredecibles. Yani, ¿alguna cosa más? Creo que tú eres la coordinadora de tu grupo.
Bueno, creo, doctor, que todo está claro y la clase fue muy buena. Muchas gracias.
De nada, todo un placer. Si necesitan algo, por favor, estoy al alcance de ustedes.
Listo, doctor. Muchas gracias.
Gracias, hasta luego.
Hasta
Gracias,
luego.
doctor.
De nada,
Doctor.
Hasta luego, doctor. Buenos días.
Hasta luego, muchas
Hasta luego,
gracias.
doctor.
de nada, hasta luego.